The added benefit of the PYLARIFY PSMA PET for someone with metastatic disease versus conventional imaging has to be broken down into different groups. Does the patient have oligometastatic disease? And that definition ranges from maybe 3 to 5 lesions. And where are the lesions? Are they confined to the soft tissue of the pelvis? Are they in the retroperitoneum? Is it a mix of 1 or 2 or 3 bone areas and or nearby soft tissue? Or are there, very far away areas of concern, supraclavicular, even calvarium, or in the skull? Are they in the sternal manubrial area? Are there pulmonary metastases? And I think that this technology is important because it'll tell us, okay, we know that we have many different options for our patients with metastatic castration-sensitive prostate cancer, but they tend to vary based upon the trial evidence of low versus high volume disease, as well as even the location of the disease, in addition to a patient's comorbidities and other factors such as their concomitant medications. But having more information to accurate staging, low to high volume, the extent of the disease, where it is, perhaps there were prior areas of radiation that can now benefit from additional radiation or not. Maybe there's even a surgical alternative depending upon where the disease is lighting up. These are really great areas of research and interest. But we can't do any of these potential studies if we don't know where the disease is. The PYLARIFY PSMA PET is going to open up that opportunity now and essentially give us a more informed decision between patient and physician. So accessibility for PSMA PET, what some would call now, next generation imaging, is key, right? I mean, this is a key aspect no matter what country you live and work in. And part of accessibility is making sure that any new technology, whether it's a biomarker or new imaging technology or new therapeutic, is affordable. It's one thing for an agency of your country to approve, but you have to have a way to get reimbursement. So reimbursement is very important. Assuming that is taken care of, what about the physical accessibility of getting an imaging technology such as PSMA PET? So there are some sophisticated attributes that come into play to create the 18F assay, and it involves having access to a cyclotron. And then from the cyclotron, once the assay is prepared and processed, there has to be a transportation supply chain that has to be developed. I'm very confident that the manufacturers of PYLARIFY have given this great thought. And at least in the US, we're lucky in that we have typically surmounted supply chain issues, especially outside of the traditional tertiary high volume centers, that many smaller hospital systems in suburban and rural areas will have greater access. The reasoning for that is that there's a longer half-life associated with the 18F assay as opposed to the gallium assay, which gives you more time for transportation once you have processed the assay.
Important safety information for PYLARIFY piflufolastat F18 injection. PYLARIFY piflufolastat F18 injection is a radioactive diagnostic agent indicated for positron emission tomography of prostate-specific membrane antigen positive lesions in men with prostate cancer, with suspected metastasis who are candidates for initial definitive therapy, with suspected recurrence based on elevated serum prostate-specific antigen level. Important safety information for PYLARIFY piflufolastat F18 injection. Contraindications: none. Warnings and precautions. Risk of image misinterpretation. Imaging interpretation errors can occur with PYLARIFY imaging. A negative image does not rule out the presence of prostate cancer, and a positive image does not confirm the presence of prostate cancer. The performance of PYLARIFY for imaging of patients with biochemical evidence of recurrence of prostate cancer seems to be affected by serum PSA levels. The performance of PYLARIFY for imaging of metastatic pelvic lymph nodes prior to initial definitive therapy seems to be affected by risk factors such as Gleason score and tumor stage. PYLARIFY uptake is not specific for prostate cancer and may occur with other types of cancer, as well as non-malignant processes and in normal tissues. Clinical correlation, which may include histopathological evaluation of the suspected prostate cancer site, is recommended. Hypersensitivity reactions. Monitor patients for hypersensitivity reactions, particularly patients with a history of allergy to other drugs and foods. Reactions may be delayed. Always have trained staff and resuscitation equipment available. Radiation risks. Diagnostic radiopharmaceuticals, including PYLARIFY, expose patients to radiation. Radiation exposure is associated with a dose-dependent increased risk of cancer. Ensure safe handling and preparation procedures to protect patients and healthcare workers from unintentional radiation exposure. Advise patients to hydrate before and after administration and to void frequently after administration. Adverse reactions. The most frequently reported adverse reactions were headaches, dysgeusia, and fatigue, occurring at a rate of less than or equal to 2% during clinical studies with PYLARIFY. In addition, a delayed hypersensitivity reaction was reported in one patient with a history of allergic reactions. Drug interactions. Androgen deprivation therapy and other therapies targeting the androgen pathway, such as androgen receptor antagonists, may result in changes in uptake of PYLARIFY in prostate cancer. The effect of these therapies on performance of PYLARIFY PET has not been established. To report suspected adverse reactions for PYLARIFY, call 1-800-362-2668 or contact FDA at 1-800-FDA-1088 or www.fda.gov/medwatch. For important risk and use information about PYLARIFY injection, please see full prescribing information at www.pylarify.com/prescribing information, or please contact your local representative.